Thank you for joining us today. On behalf of the Global Health Institute at the American University of Beirut, I'm pleased to welcome you today to our webinar titled AI-Driven Disease Health Surveillance, Enhancing Health Threat Detection with a Focus on Vulnerable Populations. This session is hosted by the Epidemic and Pandemic Preparedness Program, and we will explore how advances in artificial intelligence and digital surveillance are shaping disease detection, epidemic intelligence, and early warning systems globally, with a focus on vulnerable populations in the MENA region. I would like to start by introducing our speaker for today, Dr. Nahid Badleya. Dr. Nahid is an infectious disease physician and associate professor at Boston University and the founding director of the Center on Emerging Infectious Diseases. She is also the founding director and the co-founder of the Biothreats Emergence Analysis and Communications Network, known as Beacon. She has over 2 decades of experience in pandemic preparedness and global health security, with senior advisory roles during recent global health emergencies, including the COVID-19 and Mpox, and extensive experience in outbreak response, surveillance, and preparedness. Before we begin the main presentation, I will briefly introduce the Epidemic and Pandemic Preparedness Program and its work at the Global Health Institute at the American University of Beirut. As an overview of the Global Health Institute, it was established in 2017, and it's the first such institute in the Middle East and North Africa region, and among the very few in the Global South that addresses global health challenges through an interdisciplinary and contextualized approach. At the Global Health Institute, GHI, we function through 3 divisions. The first one, that's the programs. This is the Research and Policy Division. Currently, we have 5 ongoing programs, such as the Conflict Medicine Program, the ESAHA, that stands for Digital Health Program, Refugee and Migrant Health, the Epidemic and Pandemic Preparedness Program, which I'm going to present in a bit, and the very recently established program, that's the CLI Health, that addresses the climate change and the impact of the climate change on health. The second division that we have is the Academy. This is the capacity building, where we offer several certificates and diplomas on our e-learning platform called GLAD. For example, we have the Humanitarian Leadership Diploma, Certificate in NGO Management, and the certificate, recently established Certificate in Epidemic and Pandemic Preparedness, among other certificates found here on the slide. And the third division that we have is the Assist. This is the community service and support. We provide capacity building and strengthening for non-governmental organizations. We rely on partnerships at national, regional, and a global scale, and we have our own service departments that includes software developers, finance team, and others. Going back to pandemic, so the world is at constant risk of pandemics, and the COVID-19 pandemic was not an anomaly, rather a warning that we are not prepared. Over 70% of the world remains underprepared for a major pandemic outbreak, where the economic cost of pandemics is estimated to be over $1 trillion per year. Therefore, investment in preparedness is not an expense, rather it's a vital investment in global security and economic stability. If we zoom into the MENA region, what makes the region uniquely vulnerable is several factors, but here we're going to highlight 4 major factors. First, the ongoing conflict and instability in the region, which weakens health systems and infrastructure. The ongoing displacement of population with limited access to care results in higher outbreak risks. With the health workforce exodus, the loss of professionals and workforce and limited training, along with the unequal health capacity, this all leads to variability in preparedness across the region and in health systems. Hence, the Epidemic and Pandemic Preparedness Program at GHI, which serves as a regional and global model for preparedness through informing evidence-driven policies, strengthening context-specific capacity building, and enabling high-impact research and practice. The Epidemic and Pandemic Preparedness Program, I'm going to refer to it as EPAPP. We have successfully led 4 major initiatives. First initiative, that's the Epidemic and Pandemic Preparedness Stakeholder Map. Another initiative, that's the Pandemic Preparedness Collaboration Portal, the Preparedness Information Hub, and the Certificate on Epidemic and Pandemic Preparedness. Our work and all these initiatives were led by a framework, that's the ECDC, the European CDC framework, which outlines pandemic preparedness based on under which domain, whether it's detection and assessment, health services, coordination, communication, emergency risk communication, policy development, adaptation, implementation. And the workforce categorizes the workforce as policymakers, clinicians, public health practitioners, civil society leaders, emergency managers, and risk communicators. So to shed light on our work, so the Pandemic Preparedness Stakeholder Map, it's an online interactive stakeholder map that allows users to understand the identity of individuals and institutes and work in pandemic preparedness. In another sense, to identify who does what in the epidemic and pandemic preparedness work. So far, we have identified over 2,500 individuals across 22 MENA countries. The Pandemic Preparedness Collaboration Portal, also it's an online portal that allows policymakers, researchers, health practitioners to identify and collaborate with the researchers and experts who publish in the field of epidemic and pandemic. It's like a community of practice of researchers in this field. So far, we have identified over 10,300 individuals, researchers across 22 MENA countries. And they recently established a platform that's the Pandemic Preparedness Information Hub, which acts as a resource center for researchers and practitioners and includes practical guides, data sets, visualizations, reports, basically gray literature around the epidemic and pandemic preparedness in the MENA region. These 3 online portals are available on our website and also are now available on our mobile application if you would like to scan the QR code to download the mobile application. And the recently established certificate on epidemic and pandemic preparedness. So the thing about the certificate is that it is an evidence and needs-based online self-paced certificate made of 4 courses. And it's tailored to the MENA region. It's delivered on our e-learning platform that's GLAD, it's called GLAD. The certificate, we're going to refer to it as SAP, was developed through a very rigorous method. So after the revision of capacity building initiatives and identifying the framework, that's the ECTC framework, we did a training needs assessment followed by the Delphi survey, and this led to the development of the course. So a very quick overview of the methodology that we adopted for the development of the certificate. So the TNA survey that was sent to 95 professionals from 18 MENA countries, where we asked these professionals to rate the competencies on a scale like the importance versus the ability to perform, along with some open-ended questions to understand what are the barriers and what are the training needs. The results of the TNA was complemented by Delphi survey with 11 regional experts. We had 2 online rounds of meetings, and that was followed by a final consensus meeting where we were able to refine and prioritize the competencies. And as such, we have developed this certificate on the epidemic and pandemic preparedness, which, as I said, made of 4 courses. So the first course developed by Dr. Soha Kanj, it's the course on detection and assessment, where it equips the learners with skills needed to detect, assess, and monitor epidemics and pandemics using epidemiology, surveillance, laboratory analysis. The second course developed by Dr. Atika Barif from the Ministry of Health, it's the policy development, implementation, and adaptation, where it equips the learners with the skills needed to develop and adapt health policies for rapid and coordinated pandemic responses. The third course, that's the health services, developed by Dr. Nisreen Rizq. It allows the learner to gain the skills to prepare and strengthen healthcare systems, focusing on threat management, communication, and resilient coordinated responses. And the last course, the emergency risk communication, developed by Mr. Zahi Shaheen from UNDP, it allows the learners to develop the leadership and coordination, strategic communication skills needed for pandemic preparedness. What makes this certificate unique is first, it's contextualized. It's created by MENA professionals for MENA, by MENA experts for the MENA professionals. It's evidence-based, built on the training needs assessment and the Delphi data. The learner can take the certificate anytime, anywhere. It's online, self-paced, and the certificate will undergo a rigorous evaluation using GHI's EPAPP framework to measure effectiveness. The certificate is live. It's available on our website, and please feel free to scan the QR code if you would like to register for the certificate. Thank you. I will leave the floor now to Dr. Nahid. And please, if you have any questions, you can write them in the Q&A box, or please wait till the end of the session. Thank you, and over to you, Dr. Nahid.
Thank you so much, Noor. Before I start, I am going to put in the website address for our program, Beacon, which I'm going to talk about today for the hosts the panelists and the attendees. I'm not sure that everybody can see it, Nor, but if not, if you could share, it's beaconbio.org. And also I have the pleasure of presenting Ms. Lena Chato, who is an outbreak analyst on Biothreats Emergence Analysis and Communications Network, will be joining me today and the latter part of the presentation to provide the MENA context in particular for the subject that we're talking about today. So Ms. Chato holds a master's degree in public health and has completed the ECDC Advanced Field Epidemiology Training course, as well as the Gorn Berlin Fellowship Program. She serves as a senior epidemiologist currently at the Ministry of Public Health in Lebanon, in which role she leads numerous outbreak investigations, has overseen vaccine preventable disease surveillance with a particular focus on measles, as well as evidence-based surveillance systems in Lebanon to enhance timely detection and response. So let me start, given our time, but thank you, Lena, for joining us as well. I am going to share let me lower my hand. I'm going to share my screen and just jump right into the presentation. As Noor mentioned, we're based at Boston University Center of Emerging Infectious Diseases, which is a university-wide center that I run, where Beacon is based and where Ms. Lena Chieto is also an outbreak analyst. And we run the program in partnership with Boston Children's Hospital, as well as the Hariri Institute at Boston University for Computing and Computational Sciences. I'd like to focus a little bit about what's been done so far with LLM and large language models, in particular around disease surveillance, but then really jump into sort of the functions of our program, which has been around since April 2025. And then discuss some of the challenges we've had, as well as opportunities because of integrating LLM into disease surveillance. And then I will turn it over to Lena to discuss the disease surveillance and AI, particularly in the context of the MENA region. So I put this together partly because I thought this might be helpful for you to look at during your own time to go into a bit more detail. But large language models are pervasive in our everyday life already, and what we're seeing is integration into a lot of workflows when it comes to disease surveillance. There's some examples here that I've included that work that we've done with myself and Dr. Pascalides, but also others in the work that they've done. So syndromic surveillance and anomaly detection. We published a paper last 2 years ago at this point, this is 2026, specifically looking at picking up abnormal flu seasons from normal flu seasons, right? The ability to pick up respiratory virus seasons that might be different from prior years. And we did that based on a ChatGPT-based EHR modeling system that picked up potential changes in markers, clinical markers, including severity of disease, ICU admissions, et cetera. And you can see that paper here, which was in Journal of Biomedical Informatics. Others have done work around genomic surveillance and variant tracking, and that's, again, identifying sort of growth of variants, spread of variants, impact of variants when it comes to connecting them to presentation of clinical syndromic surveillance at the same time. The other way that LLM has been integrated in this field is digital epidemiology, which is the program that I'm going to present today, Beacon. And you can see the paper we just published on Beacon in the Journal of Infectious Diseases, which is basically a way to figure out if there are signals, if you will, for potential outbreaks or clusters of diseases through what's available online. But in our case, we actually also look at both regional sources as well as public health partners. Clinical diagnostic support is another way where here in the US, many of the electronic medical record vendors are looking at integrating answering questions for clinicians to help clinical pathways to handle potential patients that may come in that have particular syndromic constellation. Another way that AI and LLM has been used in this space is predictive modeling and forecasting. So what do I mean when I say both at regional level and facility level? So at the facility level, a lot of times you're seeing hospitals use it, for example, to forecast, starting to forecast use of personal protective equipment or certain types of medications, right? If you had influx of certain types of patients or the case mix of certain severity, how much of each of these different types of resources would be needed and staffing would be needed. And predictive modeling has been used for a while, and LLM is getting integrated into that in addition to statistical and mathematical modeling. At regional level, you're seeing regional and national level, you're seeing predictive modeling and forecasting being used to predict how big an outbreak may become. There was a lot of predictive modeling during COVID-19, as you remember, with varying accuracy in terms of spread and disease burden. But I think that LLMs add an additional potential function here because they go beyond just the ability to integrate data that is yes, no, so not numerical yes, nos, but more ability to include natural language models in terms of being able to see what might be down the road. Laboratory and diagnostic automation. And then another piece of work that we've done from our group that might be of interest is using an LLM to do drug discovery, but there are a couple of ways that this has been done. One, looking at evolution of pathogens, so antiviral resistance, for example, or evolution of COVID-19 variants, right? I think you're seeing AI and predictive modeling being used to sort of look at how pathogens are evolving. But the way that we used it in the space is we used it to scour biomedical literature. So we had a ChatGPT based model study that we published in 2024 that specifically looked at priority disease families. And what happens when every time you have a potential epidemic threat is everybody rushes to PubMed, looks for potential repurposable existing drugs and drug targets. The LLM does this for you. It basically goes through existing biomedical literature to look for potential published literature that identifies drug targets of the pathogen in those particular priority families to look to see if there's something that could be repurposed based on what's been published. So it creates the baseline knowledge on which future drug discovery research can be done. And then there is outbreak source tracing and transmission networks. I'm not going to go too much into this detail, but because I think there's a very nice paper from one of our collaborators, John Brownstein at Boston Children's, and you can sort of see some of the other studies and use cases that have been outlined in that paper. And that paper was in the New England Journal of Medicine in 2023. This is a good primer in terms of use of AI in some of the ways that I have talked about, but also additional examples as well. So with that, let me jump into what we are doing currently. So as Noor mentioned, we live in an age of epidemics. We're seeing about 70% of new pathogens are actually zoonoses. They're jumping from animals into humans. And partly it's because we're changing the world around us. The risk of epidemics is going up, even as the climate change impacts the distribution of vectors and hence the pathogens that they carry. But beyond that, I think we're growing and living in tighter, smaller communities connected with travel. And so an outbreak anywhere is an outbreak that could be everywhere within a matter of days. What Beacon specifically works on, so that's beaconbio.org. It's an open access disease outbreak platform where you can basically track any outbreaks that are going on around the world for free. And it's being used by public health practitioners, but also clinicians, where it's being used by ER clinicians, travel medicine folks, and it's being used by governments. And I'll talk a little bit more about it. And a lot of just everyday public. Actually, we get a lot of emails where people are using it before travel, for example, or using it just out of curiosity about what's going on in their own neighborhood. What Beacon works on, there are programs in the public health space that work on detection, which is they have diagnostics, on the ground case investigations, contact tracing. We don't do that. There are programs that do response, which is when there's an outbreak detected, how do you sort of respond, organize the response to it? We focus on the middle part, which is reporting, which is meant to when there is a potential outbreak to get the word out as quickly as possible and to tighten the time between detection and response, particularly at the international level. When we started doing this work, one of the things that we discovered was even as new opportunities were arising from large language models, there were a lot of challenges in terms of disease outbreak reporting, political transparency. A lot of times platforms are focusing only on human diseases, but you're seeing a lot of, as I mentioned, opportunity for spillover from animals into humans. There are many, many disparate sources. So you see public health workers going to 7 different websites to try to figure out what's happening in different regions of the world. There's not a lot of data sharing and interoperability. There are language barriers. A lot of times, even if you do Google searches, you might not get geographic scope of news beyond your region, just the way that web searches are organized. And even as a lot of other vendors exist that are integrating large language model, not a lot of others, a couple, they're all behind a paywall. So our philosophy is if you put an alarm bell behind a paywall, how do you let the world know when there's an outbreak? And how can we all respond equitably? And our philosophy of making Beacon open access is to ensure that everybody has a fair chance to respond to a new threat. So how does Beacon work? So Beacon's actually a mix of large language models and humans and networks of organizations working together. So it's based at SEED at the Boston University Center on Emerging Infectious Diseases. And at our center, we have outbreak analysts such as Lena and others based at around 12 countries. We detect signals, which either come from online through our partner Health Map, which is at Boston Children's, and we get it from our regional SMEs. A lot of times we'll hear from our subject matter experts and outbreak analysts in different parts of the world where there might be an outbreak that's not made it into the international news yet, even though it's public in that space. And we hear from public health partners, and the most pleasant surprise has been that we actually get a lot of direct website submissions. So why is this important? When you look at how MERS was detected, if you remember, it was an Egyptian physician who was in Saudi Arabia who had a non-typable coronavirus case. And he submitted that to ProMed, which was an open access platform at that time. And that's how the world came to know about MERS because the sequence was then looked at and then MERS was discovered and named. So there's ability for a platform to reach directly out to first-line clinicians and first-line public health workers and give them the capacity to share what's happening on the ground is critically important and has been, even in cases like the initial SARS-CoV-1 and the eventual SARS-CoV-2. In all of those cases, having a repository where people can send in something that's suspicious that can be verified has been the alarm bell that lets the world know that there is a threat coming. So the signals come in, our Beacon SME team screens the signals, determines what is important from a public health perspective. We don't publish every disease. I'll talk about what diseases we do publish. And we worked on training our own large language model internally that I'll tell you a bit more about. And we pick the signals that we think should be reported on. Those are analyzed by our pandemic IQ LLM, which does signal prioritization, translation, copy editing. It adds reference and historic data, while our SMEs and the outbreak analysts are verifying signals. And we verify that through on-the-ground sources or through digital investigation. We believe there's 2 sources that are not connected that are both reporting it. We'll publish it if they are sources that are trustable. When we can't verify something, but we believe the news is important, we publish it as a request for information, which basically says, look, we think this is happening, but we can't verify it. And we open it up for crowdsourced verification, which means we ask the rest of the world's community, our users, to basically send in any additional information they may have about an event. And we publish all of those in our outbreak reports. And eventually our hope is to start integrating this when we have a large enough body of outbreak reports into predictive intelligence. So our large language model was trained using a 2-phase approach. First, it integrated a large body of training library, which we will make public in the next couple of weeks, as well as as well as a task-specific instruction tuning. So what the LLM does is it takes any signals like the health map signal that you see here, it filters out those that are non-disease-based signals, extracts key information, assesses it for relevancy, quality, urgency, source evaluation, and severity, and it presents this draft report to the subject matter experts, the outbreak analysts. And then our hope is, mid 2026 that we are able to do translation into 7 languages, so the 6 UN languages and Portuguese. The second part, the task-specific instruction, is something that was done in training was done in participation with our subject matter experts, where basically based on both historic data as well as iterative training between the subject matter experts and LLM, we instilled a prompt engineering model distillation that helped with like severity evaluation in particular, which is important. So we don't share the severity evaluation publicly because, as you can imagine, there are political implications to calling something severe. But instead, we try to put that into our assessments. On the left side, you can see the body of the training library and where the documents came from. We were very lucky to have a generous grant from the Department of Energy and from NSF that allowed us to basically train the LLM very specifically on infectious diseases and outbreak surveillance and pandemic preparedness, which has really improved the output of the LLM. The severity evaluation, which I mentioned, is based on retrieval augmented generation, which is that it asks and answers specific questions about the pathogen, about the scenario. And here are some of the sub factors and key factors that it evaluates to sort of figure out if an incoming signal is severe or not. So I won't go through that, but you can see its pathogen characteristics, clinical impact and disease manifestation, transmission dynamics, geographic and demographic, healthcare system, and external risk factors. I will mention none of this makes it to the public website unless it's been looked at by a human. We edit the reports, we add additional context. And so it's not an automatic thing where you're just seeing LLM content. The LLM content is edited, sometimes extensively, sometimes not, by subject matter experts, and additional expertise and insight is placed in the reports before they're made publicly available. We compared our LLM to what's publicly available. So you can see the top ones are the models. Our models are based on MetaLlama 3, and they outperform the gold standard. And just for the sake of time, I won't go into too much detail here in terms of the methodology, but we also looked at testing our pandemic IQ LLM against published data sets, such as the biomedical alert, news and disease, as well as the multi-level disease event classification. And you can see that pandemic IQ is matched or outperforming the existing models at the time. Now, the world of LLM is like rapidly growing, right? So I think our challenge is going to be to continue sort of to also improve our models, not just to keep including new data that's coming in on the biomedical side and on the news side and epidemiological side. But also, I think that the computing power in the next couple of years is going to just explode. But for now, I think it serves a pretty great purpose. And it works hand in hand with our Beacon SME team, which, as I mentioned, was part of the large language model training and evaluation. In particular, it works to identify dis and misinformation, any blind spots in coverage, particularly in areas that may not have as much epidemiological or outbreak information online. So what happens if it's not online? It has to be a manual investigation or partnership, which is built on trust, which is why it's so important to us that our outbreak analyst network is based around the world with outbreak analysts such as Lena. The SMPT team also is responsible with developing and maintaining the ontology, the database infrastructure, the editorial priorities, as well as you can imagine, all the operational, legal, and other procedures, which keep me awake at night as the director of Beacon. We provide a lot of the context that comes up for our outbreaks that may be cross-sector. And we work to design actually the verification of the signals themselves, but also um, Beacon is based at Seed, and Seed's larger mission is education, it's research. And so there's an integration of Beacon's data into Seed's training programs and Seed's research programs as well. This is our editorial team. I mentioned we're in 12 countries. You can see that here. And there's Lena in Lebanon, and you can see some of the other countries that are represented here, speaking 19 languages and bringing in all these different editorials and, I'm sorry, subject matter expertise across the different domains. So we don't cover every single disease. So you won't find every single case of measles, for example, on Beacon, or every single case of dengue. What we focus on are sporadic cases that might be occurring in places you don't expect them to, or firsts of a particular area, or clusters that haven't been not diagnosed yet, and there's a question of what the disease may be, or if you're seeing a pattern shift in known diseases. So chikungunya is a good example. In 2025, it became a global epidemic and presented in many, many more countries with local transmission than ever before. We also present events that involve highly communicable diseases, Ebola, Marburg, things that pose public health and biosecurity risk. And then we focus on areas that are underreported, to have better understanding of what's happening. So Namibia had CCHF cases that we reported, for example, this year. A lot of times, the sporadic or even disease patterns in places that have underreporting, reporting whatever is available gives us a sense of a pattern over time, even though it's not perfect. So take it with all the caveats that are involved in terms of epidemiological methodology. So since we launched in April 2025, we've evaluated over 40,000 signals since launch, and 60% of those came from web scraping. 40% of the reports are manual uploads, so from regional SMEs, from our own within our team, versus also submissions from people online as well as public health partners. There's a long range in terms of like verification, how long it takes. Sometimes it's easy to verify something. It's already in the news in multiple places. Sometimes it's much harder. And so our goal isn't just to be the first, right? Because there's so much dis and misinformation. We want to be as fast as possible, which is why we have requests for information methodology where we just publish something we think is important if we can't verify. But we don't rush to be the first. For us, it's important to be responsible, to make sure that we're not spreading a dis and misinformation, and that we can publish with the right context. Because in reality, as most of you know, and I've been an outbreak responder, as Noor said, for a long period of time, 4 or 5 hours does not make that big a difference, even on the ground. But if you get it wrong, it can have a lasting impact for a very long period of time. Our average time to publication after an event happens is, again, between 1 hour to 24 hours. We try to publish everything we are going to publish within 24 hours of an event. And we do an average of 4 to 8 reports a day. And we specifically do fewer because when you look at our reports, you'll see that we spend significant amount of time. And actually, let me share the website to get to give you a sense of what it looks like, because I think pictures worth 1,000 words, right? So here's our website currently. So you can see, again, beaconbio.org, you can see what we call, it kind of has a social media type feed. So you can see the latest reports that have come in. And then in each of the disease event folders, you'll see the country, the summary of that disease, and over time, the reports that we have done in that country, with the latest one being on top. And each of the reports has sources from which we have verified information about what we're talking about. And then we do our own analysis, epidemiological analysis, and comparative with future outlook. This is what gives people context and the ability to make decisions on the public health level, but also policy level and clinical level. And in most of the envelopes, you will see also related resources for the general public. If they don't know about a particular disease, they can learn a bit more. And we do this partly, again, to dispel dis and misinformation, to ensure that the right information is out there. So let me go back to my PowerPoint. Okay. As of As of January 2026, we now have, so we've been around for about 11 months, 10 months, 10 months so far, 10 months, 10 months. And we've large eight technical partnerships, including with the WHO Pandemic Hub. Beacon is integrated into WHO Pandemic Hub's epidemiological intelligence for open sources platform. So if you are a user on EIOS, you probably already can access Beacon through that as well. You just have to go through and look for the filter, or it may just appear in search for a particular disease if there's a Beacon report related to it. And this is just as shocking to us as it is to you, but probably a statement to the fact that we've withdrawn so much funding for surveillance globally. We have accrued active users in 206 countries in those short 9.5, 10 months. And we've reported on 650 outbreaks and published 1,400 reports covering pathogens that range in 96 species. When the reports have been and you can see the distribution of the published reports, you can see the areas where there are not reports. It's either a outbreak has not been reported during the period of time that we've been operational, but in more cases than not, because probably in those areas, disease surveillance is not as strong. And so we're working to improve that by placing subject matter experts and outbreak analysts in those regions in particular so we can get better coverage and output. So if you're curious about why it says including outer space, we had a disease report about a Nigella bacteria at the International Space Station. So if you're interested in that, you can check it out on our website as well. And these are our Beacon users. As you can see, we have Beacon users in almost every country. And our mail digest, which you can sign up for free, it currently includes weekly and daily mail digests, and it's been followed here in the US by state and public health departments, but also aside from the EIOS integration. So the EIOS is available to 120 ministries of health, public health institutions, and organizations. In addition to that, another 21 ministries of health and multilateral organizations and NGOs follow us directly as well. And we have been working with the WHO Pandemic Hub to be both a collaborator, but also to integrate our methodology in terms of how we report talk about diseases in terms of ontologies. So that's an ongoing goal. Our goal is also to work with them potentially down the road to look at workforce development and webinars that could be hosted in the WHO Academy. So what have we learned in the last 9.5 months? I'm going to cover this quickly and then hand it over to Lena, since I think we only have like 20 minutes. So what we've discovered is that there are major advantages to using large language models, right? You can do a lot more information, analyze a lot more information, is efficient in terms of data extraction, frees up the humans to do high level context building and reports. It helps prioritize because we're looking at severity indices and things like that. It can take something from any language and translate it so you're able to sort of get information. And there are a lot of opportunities down the road, right? As I mentioned, large language models offer a potential added benefit on top of traditional statistical models for outbreak and forecasting outbreaks, because they integrate beyond just 0-1 data. You could do more nuanced data integration. We're also positioned pretty well to pick up potential novel clinical phenomena. So if a disease starts presenting with novel symptoms and we get reports of that, we can pick that up and actually train the LLM down the road to start detecting potential unusual presentations compared to what's historically been looked at with this disease. And then down the road, our goal is to do fusion of different types of data. Currently, we only integrate data that is word-based, right? Reports. But we could potentially down the road integrate genomic surveillance, wastewater analysis, so that you could have triangulation of data to potentially give you more context about a biological event. And there are some limitations. One of the major limitations is you cannot let the LLM loose completely, particularly in a politically sensitive space like outbreak reporting. You have to have human oversight. So there's not complete automation. We have a human in the loop. It's essential for verification. It's essential for editorial control. And it's also essential because the LLM sometimes cannot deal with the complexity of conflicting information from different sources. The human has to resolve that. There's also contextual analysis where there's cross-sectoral analysis. Like there's a marathon happening in Boston, and there's also this outbreak. If they're not both in the same source, the LLM's not going to be able to combine that the way a human might. I might be sitting here in Boston going, oh, shoot, we have a diarrheal outbreak going on, and we have a big marathon. So, and it's all happening in the same area. So this idea of cross-sectoral analysis, you still need a human to build on for now for large language models. There's an issue of data quality dependence because the model's accuracy depends on the kind of data that we put in. So ensuring that we get better quality data, the humans still have to play a role in ensuring that we can find that on the ground, particularly if it doesn't exist in online yet, getting digital resources that can be uploaded. And their language and regional limitations. The LLMs don't work in all regional languages, particularly there's some challenges with Arabic as well, but many African languages. And then the maintenance challenges, as you can imagine, as there's more biomedical information that comes out. Like chikungunya vaccine was one of those was pulled off the market, if you remember, because of rare adverse effects. The LLM didn't naturally pick that up. I remember making that change and saying, nope, nope, that has been taken off the market. So staying on top of that is important. So let me stop that and turn it over to Lena to now speak about the other elements. So Lena, just let me know when to move forward.
Okay. Thank you so much, Dr. Nahid, for this comprehensive overview about Beacon. And at the personal level, as I started to work as outbreak analyst with Beacon recently, I can witness that so much work and high level of accuracy is done before publishing all the reports that you can see on the website. So for me, I will present now what are the challenges concerning the surveillance in the MENA region and how can AI mitigate these challenges. Let me give you first a bit of context about the MENA region. So MENA region countries are facing, unfortunately, significant challenges that are due to the unstable geopolitical situation that are coupled with other factors such as migration, population movement, displacement, sometimes lack of resources also. So all this issue, for sure, definitely it will affect the surveillance system, and especially in low and middle income countries in the MENA region. For example, we can give some example of the most encountered challenges, such as fragmented surveillance systems. And we have like limited integration. We have like too many systems that everyone collect data on its own. So it's difficult to see sometimes the trend of certain disease, to monitor the trend of certain disease. In other settings, also we can see that they are still paper-based, and they suffer from limited digital platform, which also will slow down real-time data sharing and analysis. Also, we can see poor data quality, underreporting, missing values, and all these problems will affect the reliability of surveillance information for sure, and therefore it will lead to delayed outbreak detection. Also, in some settings, they are more relying on disease-specific surveillance instead of having IDS or integrated disease surveillance. In other places, they are still too much more like relying on indicator-based surveillance, which is routine surveillance IDS. While the event-based surveillance or reporting from community, directly from the community, will remain like weak in several countries. Next, please. So we can see that we have like many challenges that are technical challenges, but also we have other type of challenges that are more related to the system itself. For example, we have multi-sectoral collaboration. And we know that multi-sectoral collaboration is very important in surveillance, especially for human health, for animal and environment to implement the One Health approach. Also, some countries are suffering from limited laboratory capacity which for sure will affect the timely confirmation of communicable disease and especially during outbreak investigations, because we need like a quick data to set corrective measures. And for sure we have a shortage of trained and skilled staff, compounded by high workforce turnover also. And the lack of sustainable financial resources. Many of the programs are being donor-driven instead, or to have like conducted by under the ministries of health. In some MENA region, also surveillance, as we know, is disrupted by the political instability, human crisis. It will affect a lot the surveillance system. And also, to not forget the high cross-border movement. Illegal movement also can be a way to spread diseases and to have like undetected disease transmission. Next, please. So now we can move to how the AI can be a solution for these challenges. So now in our years now, we can see that AI can help a lot. For example, in digitalization, the AI-powered optical character and natural language processing could digitalize paper-based or unstructured report to make like some structured data, and it helps for digitalization. Data processing also. AI can be used to transform unstructured data such as text, image, or video, and to change them into a more structured format that can be very relevant for the early warning signals and supporting the integrated disease surveillance. Also, as Nahid mentioned, the public health threat detection, and we have here many like platform such as Beacon. It can help also to access like many source of data, scientific literature with minimal human intervention, which is very good to have like quick data and to have generate report. Also, AI can help in data analysis, in risk assessment, and in predictive models, as Nahid mentioned before. For example, in specific situations such as conflict and humanitarian crisis, they can use image-based analysis using the satellites and environmental data to assess the situation and to know where the high-risk spots are. Next, please. Also, it can be used in zoonotic disease and climate change to have like this predictive models incorporating like different data from climate, vector, and other. For example, for vector-borne disease, it will be very important. So we can have a kind of prediction and to specify the high-risk spot for these diseases. Also, it can be used for antimicrobial resistance. AI can analyze antibiogram from hospitals, from laboratory to identify what are the emerging resistance patterns and to predict resistance spread. And also for cross-border movement, AI can integrate multiple country surveillance system. It can use, for example, phone data, health data, transportation, and it can track all this information to get together to predict where are the high risk areas and to predict like kind of outbreaks. Thank you so much. This is all from me. And here we can see the reference.
Thank you. Let me see if I can put myself back on video and share those remaining slides. So I think I just want to end by saying that, you know, for us, what's important is that the program goes beyond just the platform. We have an international governance board that I'll share some members of, as well as we're forming a research and ethics committee. But our goal is to integrate a global training program. So we'll be applying for some grants to be able to welcome international scholars to work on AI use cases and global training. And partner with, you know, practitioners around the world in terms of improving the information that we provide and making our information, when we have a large enough database, right, and probably like a year or something, to make that available for external researchers to take a look at, and eventually to move to a model where we might have global hubs of different places reporting in informal surveillance, event-based surveillance space. So this is us. As I mentioned, I'm the director of the program. There are three co-directors that specifically focus on specific areas. Dr. Britta Lastman focuses on she's the editor-in-chief and focuses on all the subject matter experts and outbreak analysts. Dr. John Brownstein focuses on web scraping and platform development. And then Professor Pascalides is on the predictive intelligence of large language models. And these are our funders, and you can see our global advisory board includes Dr. Jeremy Farrar has stepped down, who's the chief scientist at WHO. He was an observer, but we currently have other public health leaders, as well as funders, as well as insight from some of our senior advisors who were part of ProMed and other important public health efforts in the past. So here's a QRS for you to sign up for the disease alerts. I'll leave this slide, but just make the slide smaller, and you can check us out on all these different other social media features as well. So let me end there. And Noor, I think we have a couple of minutes for questions. Are you planning to take questions?
First of all, thank you so much, Nahid. Lina, thank you so much for being part of this webinar as well, to shed light on the MENA. Yes, we will leave like a couple of minutes, few minutes, if someone has any questions. I'm trying to see if we have anything in the Q&A. So far, no questions. So please, if anyone has a question, feel free to write it down in the chat box or raise your hand so we can unmute you.
And while we're waiting for questions, I will say, if you have any disease reports or outbreak reports that you want to submit, you can do so by going to the Beacon website. I'll show you where on the website you can do that. On the top, add information. You can send in any reports by putting in an email and what you're reporting on, and if you'd like to be recognized in the report that we put together. So feel free to submit information. And we'll share that publicly with the rest of the world, which will help us all be more prepared over time.
I don't think, Nahid, we have any questions.
No worries.
It was excellent presentation, and thank you so much.
Thank you to the American University of Beirut for the invitation and allowing us to share some of our work, with some of the regional context as well.
Thank you so much, guys. And I hope we see you again, hopefully soon, other webinars and other events. Thank you, everyone, for joining this webinar. And we're going to end this webinar for today. Thank you so much.